We have the Minister of Health and Wellness on. Dr. Christopher Tufton, good morning.
Morning, Tiff.
Now, what is the situation regarding the ministry's contract agreement relationship with IGL? First of all, let me ask you specifically. Yes?
Yes.
Has your ministry informed IGL of what would be its projected oxygen needs, yeah, in the event of a third wave?
Right. So the answer to that is yes, and yes in bold capital letters. The fact is that we
When did
have
you do so?
I believe when we projected around the third wave as far back as May, I think it may have been, sometime in May, first of all, discussions have been ongoing with IGL. They are the sole supplier of oxygen, medical oxygen. And so it's hard not to have continuous conversations with them because particularly at a time like this when the demand is so high given the nature of this disease, COVID-19. But when the projections were made of the third wave and its likelihood, a forecasting was done to look at the likely demand based on hospitalization and looking at it at the peak of any potential third wave. I don't have the documentation in front of me, but I believe we had projected at its peak to have just over 1,000 persons in hospital requiring oxygen. And from there, you can quickly calculate what the needs are. The entity in those conversations and a series of conversations indicated what they could do in terms of increasing their demand and what they would have to do in terms of importation, really the shortfall, because their capacity would have been limited up to a certain point. Mm-hmm. In fairness to them, they have delivered on the local capacity production or targets for the most part, and but where they have fallen short would have been the importation based on the high levels of demand, and that may or may not be their fault, but it certainly was their responsibility. In at least one case, which they provide us documentation on, where they expected to get supplies, that particular supplier canceled on them because they indicated that they had to redirect those supplies to their local hospitals. I spoke to the CEO myself, who indicated that they were looking at several other sites and trying to get from those locations in Latin America and so on, but the demands were otherwise quite high. They eventually got supplies from Trinidad. So I was a little taken aback to see a statement suggesting that we had, not informed them because it's very clear. The records are there. We have always had a conversation. And one thing I know about the public health team and our epidemiologists or the units led by Dr. Webster Carr, we do constant forecasting as to what is likely to happen based on certain variables around COVID-19 and are able to project at least a few months in advance, or at least in this case around what a third wave would look like given the experiences of the first and the second, to determine what hospitalization and what deaths would likely be and what the demand for certain inputs would be. And that was all done and a conversation taking place with the supplier.
In light of that, you were a little bit surprised or you were very angry? This is damaging.
I try not to wear my feelings on my sleeve, to be honest with you, and I am expected to provide leadership. So anger doesn't solve the problem, but what I was disappointed, was concerned, and it is important to set the record straight. And I say so because there is a narrative that is emerging in certain quarters, suggesting that somehow we fail to plan and therefore plan to fail. And that's not correct.
And resulted in the loss of lives.
Exactly, and lives. So to implicate by virtue of a position taken the public health team, and it's not just about me, it's about the thousands of public sector workers, the nurses, the doctors, the the head office staff, the strategic thinkers who have risked their lives, who have worked night and day for the last 16, 17 months, and now to insinuate that somehow we did not inform, and indirectly, therefore, we are responsible for persons who may not have made it because of oxygen shortage is downright mischievous. It's very unfortunate, and I believe it has to be cleared up.
Meaning what?
Well, as I've said, I'm clearing it up now, and I will send out a release to that effect. IGL has indicated that they are going to clarify certain issues. I await what clarification they will provide.
Oh, they've told you that?
Yes. Well, not me, but the permanent secretary.
Oh.
But I am speaking on behalf of the public health system, the team of people who I know work very hard to protect this country. And it is unfair to give that impression, because that is not the case.
Mm-hmm. Tell me, another point made by IGL in its statement overnight was that only one of the 4 regional health authorities has a contract with it to supply oxygen.
Oxygen, right,
Yeah.
right.
Is that so?
That may be so, but the truth is contracts expire. Let me explain. Contracts expire and contracts are renegotiated. The length of time it takes to renegotiate a contract varies from entity to entity. In this instance, we have a monopoly supplier, a sole supplier of a life, an important commodity for public health. Lives depend on it. My own view from a policy perspective is that it is a vulnerable position to be in, and that where it is possible, we should test the market to determine if there are alternatives. Not that IGL hasn't done well, or they haven't established their infrastructure or invested and have, performed. But even in the case of good performance, strategically, the vulnerabilities that are identified with a concentration of dependence is very clear. And we're seeing the manifestations of that now, frankly speaking, in the COVID period. Beyond that, the renewal of contracts or the requirement or request for renewal of contracts came with a demand for an increase in rates. And I believe the correspondence I saw was almost 26 or 27%. So, there was a view that we should test the market to see what else was out there, not just from a standpoint of the concern about cost and the increases that were being asked for, but also the reliability or overdependence on one supplier. Now, if that is a process, and that has taken some time, but having said that, finally, the fact is the traditional and known custom is that until a contract is renewed or replaced, the terms of the existing contract applies, and the truth is IGL has been compensated in accordance with the contracts that would have been expired, but still in effect until we can negotiate a further contract. So in other words, it did not affect or should not have affected the relationship that existed during the term of the contract.
But hold on there now. This seems to be also some commercial move being made. IGL wants you to come to terms with the renewal of the contract. And you apparently, and I use that word apparently, you want to break the monopoly of IGL.
Well, again, I was hoping not to have gone there, but the release from IGL has brought these things to the fore, and if we have to talk about it, we have to talk about it. I'm saying that from a policy perspective, I think it's a vulnerable position for public health to have one sole supplier, and again, it's not a reflection on IGL's performance. I mean, if you talk to any big construction contractor, they'll tell you they don't buy tiles from one source because one day something may happen and they have to go to another source. So it's a general principle in business. But beyond that, the claims of maybe an advantage that could have been had by making these statements at this point in time.
But hold on, Minister. No, Minister. No. The point you're making cannot be lost here.
Mm-hmm.
You are uncomfortable with the existing situation where you have a monopoly provider of medical oxygen for the public health system. And as a policy, you want to change that. How are you going about changing that?
Well, the first issue, of course, is that whatever you do, you have to comply with the procurement systems that are there established in law. And so, in a case like this, you advertise. And you advertise for, with an RFP, request for proposal, to see what is there and see if anybody takes it, right? Maybe nobody is there. Maybe IGL will still be the only player.
Mm-hmm.
But certainly you give the market an opportunity to be informed of the possibility of that option and to respond to that option. And, IGL is well entitled to responding to those options. And they have in the past and have been successful at it.
Mm-hmm.
So it's not to place them in a disadvantageous position or to give anyone else an advantage. It's an opportunity to just look to see what's there based on the importance of this particular commodity.
And on top of that, given that history and the discomfort that you have, you took umbrage to them coming and asking for a 26% increase.
This is what I saw in a correspondence, yes. And I felt that one of the, and again, this is not an attack on IGL because they're an important partner, but in general business principles, where you have a sole supplier, particularly in a desperate period of time, there's always that temptation. I'm hoping that that is not a temptation that is yielded to, but there's always that temptation. Now, in fairness to them, they have said they haven't gotten an increase over a few years. But again,
how many years?
I'm not sure. I don't know if it's 2 years, I think. That's what they have indicated. But, again, Cliff, I was hoping not to bring this to this kind of medium to, create what, or reinforce or give the impression that somehow we are in some, tug and war, particularly when we need to focus on solving this public health crisis. But I really cannot allow the public health team out there, the doctors, the nurses, the strategic planners, to have an impression that somehow they have done something wrong and we have lost lives or compromised lives, nor can we afford for the confidence in their efforts to be undermined in the general population with this kind of impression being created.
Mm-hmm.
We are under a lot of pressure right now. We're being pulled from all sides because, we have a wave. We have hospitals that are overcrowded. Everybody is looking for somebody to identify with the source of the problem. And we are right in the middle of the fire.
You're in the middle of a perfect storm.
That's exactly it.
And you helped to create that storm.
Well, we can always argue that. And This is your job to probe. So probe away. But the truth is that we are where we are. And what I don't want at this time is to give an impression or have the people that I provide leadership for until the Honorable Prime Minister says otherwise, that they have somehow done something wrong. And that is what irked me about the statement, because I am, I take these criticisms all the time, and I'm immune to them somewhat. But we're talking about 17,000 people who are working overtime to provide support in public health to the thousands of Jamaicans who need it, particularly at this time. And I think that the release was unfair, frankly speaking.
Let me ask you, where are we now with the supply of oxygen? Because the shipments we got on Tuesday morning or Monday morning, we were told by the regional health authorities they would last us for between 2, 3, possibly 4 days.
Right. So when I spoke to the Instagram of IGL the early morning of the arrival of the shipment, I was told that they brought in 7 tanks of 4,500 US gallons of medical oxygen, and that plus their local capacity production would give us a week. That was what I was told, approximately a week. Of course, a lot depends on the demand, Cliff. Demand goes up and down depending on the number of people in beds. But however, he did reassure me that there were orders that were consistently on and would therefore see additional supplies coming in on a weekly basis. Now, that short-term period of usage versus replacement becomes disrupted, in fairness to them, depending on what is happening elsewhere. Because, you have a surge in Florida, then Florida keeps the oxygen for themselves. You have a surge in another area, wherever the supply is from. So this is what makes it very vulnerable. And this is what we felt a week ago with the challenges of that close miss, where we had to be moving oxygen tanks around the country from one hospital to the next.
So we should be in good stead. We should not be back where we were a week.
This is my hope. This is my hope. So the point I'm making is I'm not saying that IGL hasn't tried, and I'm not saying that we haven't worked together closely to solve the problem. I am taking issue with the contents of a release that suggested somehow that we erred in providing them with information. I'm taking strong objection to that, because what I have seen and the discussions I have had is that we had consulted on several occasions. There was an indication of what was needed or what would be needed, and there was an understanding of what could be produced versus what had to be imported.
Yes.
And I think that's important to clarify.
Dr. Tufton.
Yes.
Tell me, you have had problems with the vaccination centers, the logistics. I gather you have had high-level meetings with your technocrats and the political directorate, yes? You told us here week before last Monday, after Turtle River Park, yes? That there would be changes, there would be improvements. What are those improvements, and when are we likely to see them? Come Monday morning again, we have another Monday no movement day, yes? People not going to work, they may turn up again. What changes are you going to be putting in place?
There are a number of things that are happening now. First of all, the context is we did not have vaccines, so we could not have done some of the things that we are now doing. I'm now in Westmoreland, where we're roving the parish today. We have established several vaccine sites in communities as part of the vaccine being taken into communities as opposed to central locations. I was in Hanover yesterday, the Prime Minister in St. Thomas. So the community-based response, which will see hopefully less crowding around central sites. Beyond that, though, you will hear of specific initiatives that are going to be set up for particular sectors, PRISM and BPO and others. And the Prime Minister has been instrumental in this, by the way. He and I have consulted. We have had several meetings. And so we will give details of that in a day or two. And those initiatives will begin or have begun and will become more apparent. Beyond that, we trained private hospitals on Monday, as well as school nurses. And over time, we expect that vaccines will be available in private hospitals, an arrangement with the government. We will compensate them for the administrative component of the vaccines. Vaccines are free to the public. The private sector initiative is expanding, as I said earlier. Our school nurses are going to be a part of the program. And then we're looking at a number of private companies with an RFP to be issued to come in and give us their ideas around going out in other locations to vaccinate populations in targeted areas. When all of this is achieved, and there will be some sort of oversight over this process, when all of this is achieved, Cliff, what you effectively will have are more outlets and less need for crowding.
Yes.
And I think it has started. Where I said I'm in Westmoreland now. You'll see more of it in the days to come.
Another one related to that. We had Professor Winter Davidson here yesterday, and Professor Alveston Bailey, and both were in agreement that one of the weaknesses of the national vaccination program is the non-involvement and inclusion of the 8 to 10,000 private doctors up and down this country. Why have you been reluctant, yes,
Right.
to really include the private medical practitioners?
Right. So we have not. I mean, a lot of the vaccination blitz that we have had, we have drawn on private doctors using the umbrella bodies, the Jamaica Medical Doctors Association and others, to source these persons. They have been paid for these sessions. The private sector initiative has used private doctors and nurses. They have used some public too. And the outsourcing that is going to happen will involve private doctors. Now, if they're referring to private doctors in their place of operation,
yes,
that's a different thing. And that is so because, for starters, we have to get an indication of those who are interested so to do, given that they have their own arrangements for delivering service and their patient load, and the additional load is easier said than done, and not as many people are as interested as we think. Secondly, their location will have to have a minimum level of infrastructure. Storage of the vaccines, for example, is not as is the case with other types of medication. There would need to be a dedicated storage area, temperature control, because if you adjust too much, you spoil the vaccine and so on. So those are things that have to be considered. Now, we're starting with hospitals because they have a natural infrastructure to deal with those things, adverse reactions and so on. They're hospitals, so that's what they do. And then we go to some of the more established private facilities that qualify to provide this service with the protocols.
Mm-hmm.
I don't think that all doctors' offices, or the majority of them, frankly speaking, would qualify to offer the vaccine because of those technical reasons.
Mm-hmm.
And that's the conversation we've been having internally.
Yes. One final one, and then I know you have to go.
Yes.
Come Monday, vaccination day again. Yes? We're not going to have the situation where Jamaicans are having to turn away or having to wait 4 or 5 hours in the sun, not being moved along.
Well, you know, in this thing, you can't give no guarantees. And I'm hoping that...
The buck stops with you, though.
Yeah, well, always. It will get better, I think, with time. I think the circumstances around the crowding last weekend was that there is a fear factor in the country at this point, given the third wave, given the scenes of hospitals out of bed, people waiting, that sort of thing. And it has created a rush on vaccine sites. That in a way is a good thing. In another way, it's not so good. Good because it overcomes the hesitancy. Not so good because many turn up not registered. And you plan to cater to 1,000 and 2,000 turns up. No location is going to be able to function efficiently 100% of the time with that kind of unpredictability. And that's why we have an appointment system. But that appointment system works to a point. If people go on the system, and the appointment slots are full, they just turn up. And if they turn up, you try to accommodate them, because if you turn them away, they complain. And when you try to accommodate them, they don't want to wait. So it really becomes a challenge. And the way to address that challenge is to open up more places to allow vaccines to take place. And I think that's where we're headed in the days and weeks to come. And I think it will get better from we do that.
Thank you, Dr. Christopher Tufton, Health and Wellness Minister. Thank you.